So this class is on the role of minimal residual disease in multiple myeloma. So this is how the talk is going to go. I'll be taking the talk in different parts. Initially, I'll be telling you why we need MRD testing in myeloma. Okay, how do we assess the response in myeloma? What is the conventional response criteria, and what are the updates in the response criteria? Okay, then how do we use MRD results to improve the outcome in myeloma patients? And finally, on next generation flow cytometry for myeloma MRD. So if why do we need MRD testing in myeloma? So all of us are very comfortable of sending MRD for B, ALL, T, ALL. Until recently, we were not sending MRD for AML. But then now more and more institutes have started sending AML MRD. Myeloma MRD is a new kid in the block. So not all hospitals routinely do MRD for myeloma, except for institutes like Tata. So why is that we need MRD testing in myeloma? So if you see the treatment landscape of multiple myeloma in early 1980s, so we used to treat myeloma with vincristine, adriamycin, doxorubicin based therapy. Then we went on to the stem cell transplantation. And in the last 5 years, there is a paradigm shift in the treatment of myeloma. We started using immunomodulators like bortezomib, lenalidomide, and then came the monoclonal antibodies like daratumumab, pomalidomide, carfilzomib. And now we are at the stage of CAR T cell therapy. So if we see with these initially where when the myeloma patients less than 50% used to achieve complete remission. But with this advance in treatment, we see more and more patients are achieving the state of complete remission. Okay, complete CR. But the most frustrating part is that despite achieving but assessing the depth of response to find out the cohort of patients among the complete response who are most probably likely to recur or who have a poorer prognosis. So, if we see how the traditional way of assessing myeloma response following treatment, all of us are very well aware. We have this partial response, very good partial response, complete response, stringent complete response. So this is based on the electrophoresis, the immunofixation, the imaging studies, and the bone marrow examination. So if you see, a patient is said to be in complete response when the electrophoresis does not show any impact, IF is negative, and imaging, there is a disappearance of all the plasmacytomas. And when we do a bone marrow examination, there is less than 5% plasma. And the patient goes into stringent complete response once we do IHC in this bone marrow and prove that there are no clonal plasma cells in the bone marrow biopsy, the patient goes into stringent complete response. So, but as I told, despite these patients being complete response, we see, this, if we see the patients who are in complete response or stringent complete response, they have a better survival following treatment if they are achieving CR. So this is the graph that shows that. So that is why we try to see whether following treatment they are coming into the complete response. But despite achieving this complete response, we see that a lot of people are coming back with recurrence. So that is why the International Myeloma Working Group had come up with this detection, MRD detection. Okay, as of now, if there are flow cytometry MRD negative criteria, the sequencing MRD negative criteria, image negative MRD criteria, and sustained MRD negative. So what we are interested in is flow MRD. Okay, I'll be talking about sequencing MRD in the last part of the slide. So in flow cytometry, what we say is that the absence of aberrant clonal plasma cells by next generation flow cytometry. It is not the routinely done flow cytometry in the lab that labs do flow cytometry routinely for myeloma MRD, but it is the next generation flow cytometry assessment of absence of clonal plasma cells. So what is next generation cytometry? That I'll be telling how is it different from the routine diagnostic flow cytometry for MRD. I'll be telling in my latest slide. Okay, so that is once you do this flow and there is no residual disease, then we say that it's flow MRD negative. And once we do sequencing, no residual disease, we say sequencing MRD negative. We do imaging, but to tell a patient is imaged MRD negative, we need to first do MRD negativity by flow or sequencing, plus the disappearance of lesions on imaging. And any patient is told to be in sustained MRD negative when the MRD is negative in the marrow, either by flow or sequencing, as well as by imaging for a duration of 1 year apart. We call them as sustained MRD negative. Okay, but please note that before categorizing these patients into MRD negative, they need to require to fulfill the criteria of complete response. Because our aim is to find those patients who are among complete response, who are going to fare better or who are going to have a poorer prognosis. So if I say, so this is a slide which shows that what is the sensitivity of different methods. So in complete remission, we assess the response status by IF, electrophoresis, and bone marrow biopsy. Okay, so when all these are negative, we say the patient is in CR. So here we are able to detect only one cancer cell in 1,000 cells. When you do IHC in bone marrow biopsy and prove that there is no clonal plasma cell, the patient comes into stringent complete response. Here we are detecting one cancer cell in 10,000 cells. Coming to next generation flow cytometry or next generation sequencing, we can detect one cell in 1 million cells. Okay, this naturally proves that this is the most sensitive technique to detect the residual disease in myeloma. So the conventional approaches that define the complete response is a low sensitive method. So hence it is expected a patient who is having an MBAN negative following treatment or an IF negative can have a flow MRD positivity. So this was a study by Rostrom where he saw that nearly one-third of patients who were negative by immunofixation were positive by MRD on flow. Okay, so immunofixation has a lot of limitations. I think Dr. Malu will speak a lot about the limitations of IF and immunofixation. But with the current treatment protocol, one thing which has to be highlighted is that the patients we do use daratumumab, which is anti-CD38 for myeloma treatment. This is a monoclonal antibody, IgG kappa. Okay, so if the patient was initially a myeloma with IgG kappa, once we do the electrophoresis of IF, we will see this monoclonal IgG kappa due to that. So we are not able to distinguish whether this monoclonal IgG kappa is due to DARA or due to residual disease. Okay, for that we need to have mass spectrometry. So this is one of the major limitations which we have to keep in mind while assessing response on DARA patients. Okay, so now I've told you why do we need MRD, what the response criteria. Now I'm trying to convince what is the use of MRD, how can you use MRD to improve outcome in myeloma patients. So a lot of studies have come up proving that MRD negative patients have a very good prognosis. So now this slide asks the query that is MRD negative is going to be the new stringent complete response in the future, because that is the way by which we have made advance in the therapeutic landscape of myeloma. Okay, we are getting patients achieving more and more very good response, and comes up the query whether MRD negativity can be considered the new stringent complete response in future. Okay, so if we see in this graph, the patients who are achieving MRD negativity, their chance of clinical progression is quite delayed or quite late compared to those who achieve partial response, very good partial response, or complete response. So this was a study by Rostring, where he studied the impact of MRD negative status in high risk and standard risk myeloma patients. So if you see this blue line is MRD negative in standard risk, okay, and the green is MRD positive standard risk. Definitely, MRD negative standard risk have a better progression-free survival than MRD positive standard risk. Okay, progression and overall survival. And MRD negative high risk, that is the yellow line, and the MRD positive high risk, which is the orange line. So comparatively, the MRD negativity has a better prognosis or better overall and progression-free survival. Okay, this was a study done on following stem cell transplantation, where patients in complete remission after stem cell transplantation with persistent MRD have found to have similar outcomes to patients who are not in complete remission or in partial remission. Okay, so if you see This blue line is MRD negative patients, and this positive orange line is MRD positive patients, and definitely they are having a better prognosis. This this was another study by Rostrom where he showed that flow cytometry will help to predict the outcome in post-transplant patient. If the patient has a MRD negativity, definitely they are going to fare better. Okay, so these are a lot of studies have proved unrefutably that MRD do have an impact on the overall and progressional survival, especially following transplant. We can while assessing at day 100 and and even after non-transplant patient also. So the depth of response after therapy not only helps in determining the long-term outcome, but also highlight the immediate identification of patients with imminent relapse or poor survival of less than 2 years. Okay, so coming on to so MRD detection can be done by various methods, flow cytometry as well as sequencing. Okay, so coming on the next generation flow cytometry for myeloma MRD. So who are the patients who should be tested for myeloma MRD? So as I told, we are trying to find out the patients who are having a poorer prognosis among the cohort of complete response. So all patients with complete response can be treated. Okay, and when do we plan for MRD? As of now, there's no guideline of when to send for MRD. But we can plan for MRD testing in every phase of treatment or whenever a bone marrow sample is obtained in those patients with complete remission. Okay, so the pre-analytic factors, the sample taken as a bone marrow can be taken in EDTA or heparin. As in any MRD, the first full marrow is what is required. Okay, the difference of myeloma MRD from other MRD is that the plasma cells are very fragile. Okay, so we cannot afford to keep the sample for 2 to 3 days. Whereas BMRD, it's okay if you can, even if you process after 1 or 2 days. Okay, so in myeloma MRD, we need to process the sample in 24 to 48 hours. And if it is more than 24 hours, we need to store it in a medium called as RPMI medium. So if we are doing MRD, please call up the lab and inform prior that we are having an myeloma MRD sample being coming. So and please early morning itself so that we can process on the same day. The samples are preferably stored in 25 degrees Celsius, that is normal AC temperature. Refrigeration is not recommended because refrigeration will affect the stability of one of the antibodies that we use for plasmatal detection, that is CD138. So this was a study by So KD where he found that while storing at 4 degrees Celsius, the CD138 shows a definite degradation following which starts from 48 hours. So the sample is preferably stored in the normal 25 degrees Celsius, that is normal AC temperature. And also, please do send a history of anti-CD38 antibody usage by treatment you've taken for the patient, because the detection strategy or analysis strategy for those patients is different. We need to add extra antibodies which can detect the plasma cells other than the conventional 38-138 in these cases. So the sample quality is very important because poor sample quality, in my previous talk of BMRD also told that, is one of the main fact why we have a false negative MRD. So the poor sample quality can be because of the blood clots or because presence of blood clots or large sample volume. We are getting 5, 6, 7, 8, 9 bottles of EDTA and which is not numbered. We don't know which is the first pool, which is the second pool. Naturally, after the first 5 ml, the sample is going to be dilute. Okay, so you need to mark the bottles, make it a habit marking it even in diagnostic manner, so that we know which sample is going to be the representative of the marrow, and sample volume or hemodilution is one of the cause of poor sample quality, and sample which is going to be assessed more than 48 hours definitely is not going to be the sufficient sample. So one of the advantages of flow MRD is that we can assess the bone marrow sample quality unlike in sequencing or other methods, because and how do we assess the bone marrow sample quality? So in flow can tell whether the sample I have received is a hemodiluted or a representative of the marrow, because we look at the cells which are marrow representative, like the mast cell, hematogon, myeloid precursors. These cells are not normally found in peripheral blood. So when we see these cells in adequate number in the marrow, we can say that yes, this marrow is representative or is not hemodiluted. So we have a lot of centers who are giving us myeloma MRD reports. So how do we know whether the report that we have got is a standard one or a quality one. So what are the parameters that we should look for? We should look for the number of events acquired in that sample. Okay, so in BMRD, if you remember, I had told we need minimum of 5 lakh events to get a sensitivity of 0.01%. In Myeloma MRD, the sensitivity is what we try to achieve is 0.001%. Okay, so and also we have the problem of plasma cells being very fragile, which need to be processed within 24 hours. Okay, taking all this in account, the recommendation is that at least 2 million events have to be acquired for myeloma MRD, at least. So what is preferential is that 5 million events minimum should be achieved for reaching a sensitivity of 10 raised to minus. So for assessing the quality of report, first look at the number of events acquired, see whether your sample is hemodiluted. So a good report will have these parameters which shows whether the sample is hemodiluted or not. Okay, and see whether the panel used is adequate. Yeah, if you're using a daratumumab, in a dara patient, if they're using conventional myeloma panel, that will not be suffice to identify the clonal plasma cells. We need to use extra markers. Okay, so the analysis of the panel. Of course, if the lab is taking part in the EPOS, that is a basic quality indicator. So this is a myeloma MRD panel that we do in MBR. We have the CD45, okay, and the 138 and 38. These are the markers which by which we identify all the plasma cells. And then we have other markers to say whether they are normal or reactive. That is the 19, 27, okay, 56, 117. And finally, to see whether they are clonal or polyclonal or monoclonal, we use kappa and lambda. So the strategy is that initially we identify all the plasma cells, and then we try to see among these plasma cells what are there any clonal plasma. Okay, so CD319 is one of the antibody we have included in all our panels because this is one antibody which is used to identify plasma cells when the patient is on daratumumab. Because then the anti-CD38 will not work. So we need at least 2 myeloma markers. So here then when we will use 138 as well as 319. So this table shows us that how a normal plasma cell expression of these markers are different from that of the abnormal plasma cell. Okay, so I don't think I'll go into detail of these. CD56 is a very robust marker because abnormal plasma cells, so this is the marker which usually helps us to identify the abnormal plasma cell, which is going to be strongly positive in abnormal plasma cells compared to normal plasma cells. Okay, but final ultimate thing is the cytoplasmic light chain, whether they are clonal or polyclonal. So this is one of the graph of one of the patient whose MRD was tested here. So if you see the events acquired was 6 million. Okay, and then we have taken out the singlets. We have excluded the doublets. Okay, I told that initially we are trying to isolate all the plasma, and the isolation plasma cells in a normal not patient was not used enough. We use it by CD38 as well as 138. Okay, the plasma cells have very strong CD38. 138 kind of moderate to strong. 138, but it's not a very nice antibody because it is the antibody which starts degrading very fast. Okay, so with CD38, 138, and 45, I isolate all my plasma cells here, and then among this population of plasma cell, I try to identify whether there are any reactive or clonal plasma cells. Okay, so I go 656 in this case, but it's not always. If you see, whenever a panel has multiple markers, that means that the single marker is not a good enough marker to identify anything abnormal. Okay, so in this case, it was a straightforward case where this we see a population. So my in this gate, I've included only plasma cells. If you see, from the initial gate, I have purified out. So initial gates, in a panel, we are going to have record, you're going to have myeloid cells, plasma cells, so many things. So that is included in the initial plots. And then I gate out my plasma cells only by 38, 138. And finally, in these gates, I shown only plasma cells. I purified out my plasma cells, and I'm trying to find whether there is any abnormal cell. So if we see among the plasma cells, there is a small tiny population which is CD56, right? Okay, which is kind of 27 dimmer than the rest of the plasma cell. So I give it a different color and I look for the kappa lambda ratio. So my blue population, which is a normal plasma cell, has a very nice kappa lambda membrane ratio, whereas my red population, which I suspect to be the clonal plasma cells, are definitely kappa restricted. Okay. So this is how we give the report in MVR. So we say what is the sample or what are the instrument gating strategy. You can see the markers used here. Then the time point. We say what is the total number of events acquired. Okay, minimum at least 2 million is to be acquired. 5 million is very good. And then we see whether MRD is positive or not. What is the percentage of MRD? 0.04. And this 0.04%, how it is abnormal, what are the markers that came abnormal, and what was the restriction, kappa or lambda, we can see within this table. Okay, and then in the end of the report, we do mention what the hemodilution parameters, and if it is hemodiluted, we say the sample is hemodiluted also. So this patient, as I told, flow MRD has a very good sensitivity compared to IF and electrophoresis. This patient did not have any MBAT on electrophoresis. Immunofixation showed IG. Patient was an IgG kappa. We see from the it was kappa restricted. So, but then in the IF there was a polyclonal IgA which was not related to disease. So according to the criteria, he is in complete response. But there is a 0.04% significant amount of MRD in this patient. So maybe that is going to affect his prognosis. So when do we call an MRD positive? Anything more than 0.001% is considered as positive MRD in myeloma. So one of the so it is not that flow segment is foolproof. It does have some limitations. Myeloma is a disease known for patchy involvement. Okay, so there is a potential for false negative in MRD in myeloma if we are aspirating the uninvolved or marginally involved site. Okay, and the patient can have no disease in marrow, but the presence of extracellular disease. But still, that is so. In that case, also the flow MRD can be negative. And also, I told that myeloma plasma cells are very fragile. The fragility of plasma cells, the time, sample quality, the preparation time, the analysis time can all bring out, of course, false negative MRD. So this calls for the importance of imaging. So we have this criteria of imaging negative MRD. Okay. So because we have seen that one is that patch infiltration, where you have MRD negativity, imaging can pick up. Okay. The another thing, this was a study where they have found that around 12% cases who were negative by MRD was found to be positive in imaging, and they had poorer prognosis. Following transplantation also, extracellular relapses are likely, even for following transplant. So following transplant day, we did flow MRD is negative, but for a complete comprehensive evaluation, we need to do the imaging to see whether the patient has any extracellular disease or not. Okay, so that was on, so the flow MRD is called as the next generation of cytometry because in routine diagnostic myeloma, we don't use so much of events. So the number of events acquired and the extra panels that we use in Dara patients, that is how it makes it different from the routine diagnostic MRD. I mean, the diagnostic myeloma case analysis. So we have other methods for MRD detection, which is the sequencing. But the disadvantage of sequencing, whether it is allele specific quantitative PCR or VLJ sequencing, is that we need to have a baseline sample. Okay, in flow cytometry, even if I don't have the baseline flow report, I can do an MRD. But for sequencing, we need to have a baseline sample. Okay, and then it is very labor intensive. The turnaround time is very high. The cost is very high, and it is not available commonly in most of the places. But then the sensitivity of both are said to be comparable. So what is the future in myeloma? Future is the liquid biopsies because we know marrow aspiration is a very painful procedure and patients are often reluctant for marrow. Okay, so in future, people are trying to analyze the free circulating DNA in bloodstream. Okay, sequencing methods can detect even a small number of circulating tumor plasma cells in peripheral blood or tumor cell DNA in plasma. And the sensitivity of this technique is quite high, actually, 0.0001%. It can able to detect less than one cell in 1 billion. So that is hopefully going to be the future. Okay, to summarize, myelopathy is undoubtedly having a very good prognostic significance. It has a it does affect the overall and progression in survival in patients. In any clinical trial, now the endpoint is what we require is an MRD negativity, especially in an institute where we are doing a lot of trials. So whenever we have to publish any data on myeloma, we to say the patient is in has responded well. Always an MRD negative report has more validity than just saying that the patient is going to be was in complete remission. Okay, so as of testing in clinical practice, does it have any importance in decision making of treatment? Not in guidelines so far. So International Myeloma Working Group has just proposed this MRD testing, but it does not have not incorporated in guidelines. It does not affect the management of patient, but then the clinician can be a bit more comfortable in when you have a low MRD negative to change the patient into maintenance, or that is a personalized way of treatment. But it definitely in future hope that it is going to be having a little bit more significance. Okay, there are ongoing trials which have been listed below. That have are evaluating that MRD adapted therapeutic approach, which can provide insights into the benefit or risk of escalating, maintaining, or de-escalating, or when restarting treatments based on the MRD status. So that was all on the myeloma MRD. Any questions?